All right, Dr. Gillard here. Welcome to another video. It is the fall. It is week 2, and I know everybody is so excited to learn the language of dermatology. How are you going to refer a patient to a dermatologist if you can't write them a letter and explain why you are making the referral? And so we need to learn the language that dermatologists use when they talk. That's what today is. This is part 1. We'll do a little bit of this next week as well. Okay, got to know how to write that referral letter. Before we start, just some just to help you get an idea of gauge diameters. So a number 2 pencil, run-of-the-mill number 2 pencil, has a diameter of about, a normal one is 5 millimeters. Those little extra big ones are 6 millimeters, but a regular run-of-the-mill is 5 millimeters. Tip of acrylic crayon, 2 millimeters. Tip of a number 2 pencil is 1 millimeter. And 11 millimeters, right? 1.1 centimeters is 11 millimeters. That is the diameter of a AAA battery. So that will just give you, and you'll see why we need that in a minute. All right, so what we need to start learning how to describe lesions. So if you have a flat lesion that is less than 1 centimeter in size, it's called a macule. Macule, right? It cannot be raised. Close your eyes, run your finger over the lesion, and it can't be raised. If it's raised, it's a papule or a plaque, and we'll talk about that in a second. Okay, it doesn't have to be perfectly round. This one's fairly round looking, and it doesn't matter how deep it is. It just has to be flat and less than 1 centimeter or less than 10 millimeters. Got it? Pretty simple. Okay, it could be like an iceberg. It could extend way down like this, but it doesn't matter as long as it's flat. Watch out for this. I've tricked you before in the test and wrote the word macula, right? This is not a macula. This is a macule, like a mule. Macula, of course, is the center of the retina. The fovea centralis would be right inside of that. So that's kind of the most accurate part of vision. So don't get those confused. It's the macule. What are some examples of macules? Freckles are great examples of macules. Okay, they're less than a centimeter or less than 10 millimeters in size, and they are flat. Okay, macules can be different colors. They could be brown, they could be blue, they could be red, they could be hyperpigmented, or another way to say that is variegated. I won't spell it out any further. I'll show you that in a second. Okay, so these are all different types of lesions. This one's even cancerous. It's extending into the dermis, or at least precancers. But it's still, all of these are presenting as macules. Got it? How about some examples of brown macules? Café au lait spots. Melasma, we'll talk about that one a little bit. The mask of pregnancy. Freckles are also known as Ephelides. Ephelides. Those are freckles. Or Ephelides is a single freckle that you're talking about. Lentigo is another example. That is so common. We need to talk about that. Fall down a little rabbit hole here in a second. But what if it's, I know some of you are thinking, well, what if it's over 1 centimeter in size and it's flat? Then it's called a patch. Patch. Okay, so patch is flat, same thing. It could be different colors, but a patch is nothing more than a big macule. Got it? It's bigger than 10 millimeters or bigger than 1 centimeters. Again, it doesn't have to be perfectly round or perfectly, but it does have to be flat. I should make a note here that some of the medical texts don't acknowledge the existence of this patch. The chiropractor for dermatology does, so I had to put it in here to get you ready for boards. But you'll see why in a second that patch really isn't a good term. And some authors just say a macule is is any flat lesion. When we start talking about rashes, you'll see why that is in a second. Right? So macule, less than 1 centimeter. Patch, greater than 1 centimeter. And the depth doesn't matter. It just matters that they're flat. Right? How about a famous? Here's a famous flat lesion here. So this is a patch. It's definitely bigger than a AAA battery, right? Anything bigger than a AAA battery, or AAA battery is 11 millimeters, so anything the same size or bigger than a AAA battery is not a macule, it's a patch. So this is a patch, a red patch, and this has got a name. This is called Nevus Flammeus, or Nevus Flammeus, and it's also known as, more commonly, the port wine stain. Just a little information about that port wine stain. They're usually flat with a passage of time. About a quarter of them become nodules, so they can develop some nodular growth. The large ones can actually follow dermatomes, and they absolutely love the face, unfortunately. Specifically, they love to follow the trigeminal nerve, one of the V1, V2, or the V3 distribution. This one is actually up in the ophthalmic branch of the maxillary nerve, right? We'll see some down here. V2 is the maxillary, and you can see them down here in the mandibular branches, V3. Now, this is not shingles. It has nothing to do with the virus, and why it follows these dermatonal patterns, we don't really know the answer to that. Okay, what are they? They're actually mutated red blood cells, specifically the endothelial cells, develop mutations which makes them proliferate like crazy. So you have crazy, twisted, anomalous blood vessels that are so smashed together they take on this red appearance. Okay, and it is considered a capillary malformation, so that's where this occurs. This is typically present at birth, so you could consider this a congenital lesion. All right, here is some little babies. The treatment, by the way, there's a laser treatment that is very successful for these, and this is a port wine stain in V1 and V2 in this little one. And this one gets snuck up in V1 and V2, mostly in V2. And notice how the other side of the face isn't really affected. And really a dramatic result here after laser therapy. I won't go crazy into that, but it's not always, this is probably an exceptional result. It doesn't always look that good. But if they're flat and they've just started out, it does pretty good. If they start getting nodules, you're not going to get rid of the nodules with that. Another common example of a patch is a vitiligo lesion. That's definitely bigger than a AAA battery, right? And so that's kind of the opposite. This is an area where no melanocytes are present, and we'll talk about that later on in the class. Here's another example of a patch. See, patches, you know some of these, right? Kaposi sarcoma can present initially or in the intermediate stage as a patch. It can become raised later on in the course of this disease. I used to actually cover that. We don't have time to talk about that one anymore, but I do have YouTube videos on that. Never enough time for dermatology. Really, as I've said before, we need to make this a much longer. It's only 45 minutes, and we need to make this a 2-hour class to get all my dermatology in. The other thing about a port wine stain or Nevus Flammeus, watch out for these ones down here. If you're the type who doesn't have an x-ray machine, which you probably won't when you first get started, these are warning signs. A lot of times there's a spina bifida or transitional segment, or there's something weird going on down here. So be careful with grade 5, crack, that's a grade 5 manipulation down here until you see what's under there, because that often indicates a problem. Okay, a rash is called in dermatology speak an exanthem. It's just an eruption of skin lesions that pop up in at least one region of the body. It can result from a virus or an autoimmune, so you could say it's autoimmune attack of the skin or an infectious attack of the skin. And when you're describing rashes, the word exanthem always comes last, and you put adjectives to describe. If you just say exanthem, well, they got some outbreak of lesions, but you don't know, is it a red? Is it made of papules or macules, or what's the deal with the thing? Is it itchy? So we have to learn how to describe these rashes a lot better. So this is an example. So most of these lesions are under 1 centimeter in size. They're flat and they're red. So how would you describe that? Well, we know what the lesions are. Those are macules if they're under 1 centimeter in size. They're red. The word for red, of course, is erythemic or erythematous. So we have erythematous, meaning red, macular, meaning the rash is made up of macules, and exanthem means rash. So if you write in your report, Mr. Smith has a erythematous macular exanthem, the dermatologist can go, okay, he's got a red rash that's made up of lots of macules scattered all over the place. And here is where a lot of the authors don't like the word patch, because this is there are actually some patches here. That's probably a patch, right? That might be a patch bigger than a AAA battery, bigger than 10 millimeters. And so there is no such thing as a papular exanthem. It doesn't exist. That's why they don't like the word patch. So even if you see some patches, you would still call this a macular exanthem. All right, so I think we got that one covered. What are some examples of these, or what are some causes of viral exanthems? We know these, right? Measles, rubella, varicella or chickenpox, roseola, Fifth's disease. These are all causes of exanthems. All right, so we got the flat players down, basically the macule and the patch. How about the raised players? So very simple. We got a papule, a plaque, and then we got a new player, lichenification. So let's take on the plaque first. So this is an elevated lesion that's less than 1 centimeter in size. So it's really just a macule that's not flat. You can think of it as that, a macule that's not flat. Caused by metabolic deposits from the condition, or infiltrates. If it's cancerous, it could be cancer cells. It could be hyperplasia of the cells getting really thick. The keratinocytes have become really thick. Could be cancerous, could be benign, could be precancerous. The key is it's a raised lesion that is bigger than 1 centimeter. They come in all different colors. They can be flesh color, the color of your skin. They can be yellow, white, red. They can have different tops to them. These raised lesions can be dome-shaped, cone-shaped, flat, variegated, vegetated. They can be lumpy, bumpy. Here's an example of this. So here's a yellowish one of maybe a lipoma, and it looks yellow because of the foam cells within it. Here is a red one. Here's a lumpy, bumpy one that's kind of flesh-colored. Okay, again, the depth of it doesn't matter. As long as it's bigger than 1 centimeter, you got yourself a papule. Or less than 1 centimeter, you got yourself a papule. Here's a fleshy color papule, less than 1 centimeter. Here's another one, papules. Obviously, you compare AAA battery would be maybe a tiny bit smaller than the umbilicus or the belly button, but those are definitely smaller than a AAA battery. Those are papules. So let's add to our descriptions now on rashes or exanthems. So now if you have a rash and it's made of little raised lesions that are less than 1 centimeter in size, you got yourself a papular exanthem. Papular exanthem. If the exanthem contains a mixture of macules and papules, what do you call it? Well, a maculo-papular exanthem. They don't usually call it a papulomacular exanthem. I guess alphabetically M comes before P, so they tend to use the word macule, M, macula, and papule secondary. Okay, so maculopapular exanthem. Now, what if it's red in color and it's a mixture of macules and papules? Well, then you got yourself an erythematous maculopapular exanthem. See how that works? How about let's add one more descriptor in there. What about itchy? What's the word for itchy? Pruritic. Pruritic is the word for itchy. So if we have an itchy red lesion that's made of macules and papules, and it's a rash, it's scattered in at least one area, you have yourself a pruritic erythematous maculopapular exanthem. See how that works? And that the dermatologist looks at it. Oh, it's itchy, it's red in color, it's made of macules, and it's made of papules. Got it? Not that hard. So if we look at this lesion, there are lots of little macules. Some of them are definitely raised looking though. They're all small. Even though they've all clustered together here, I think it's still safe to call this, from the history, the patient says it's itchy. This would be a erythemic pruritic maculopapular exanthem. Or you could put the pruritic at the beginning if you want. Pruritic erythemic maculopapular exanthem. See how that works? All right. Now, what if the raised lesion is bigger than a centimeter? So now, if it's bigger than a centimeter and it's raised, this is where a plaque comes in. Don't get plaque and patch confused. Patch is flat, like if they patch your jeans, pretty flat, maybe not perfectly flat. But a plaque that hangs on the wall or sits on your desk, it's thick, right? It's usually thick, like this congratulations here. So that's how I remember it. Plaque, okay, it's thick. It's definitely bigger than 1 centimeter, right? Now, another thing, the key with a plaque is, because a plaque can be very similar to a lichenification. You can get those mixed up. So the key is a plaque has very well-defined borders. We can tell where this plaque starts and stops, no problem. Lichenification is not true like that. It's a raised lesion bigger than a centimeter, but you can't tell where it starts and where it stops very good. So this is an example of a plaque. It's about 3 centimeters, certainly bigger than 1 centimeter. And you can see the borders are quite sharp. You can see the skin stops and the skin starts, or the lesion starts right here. So this is best described as a plaque. Sometimes patients start out with papules and they get closer and closer together where you can't tell the difference anymore. So papule can turn into a plaque with the passage of time. And again, the surface could be rough, it could be smooth, it could be hairy, it could be crusty. None of that matters. It just matters the size, and it's raised and it has a well-defined border. That's a plaque. Right? Here's another example here. Anybody know what this is, by the way? I don't think I've ever had anybody. They can usually figure out what tissue it is, but they've never caught this. This is the classic. Last year's hat didn't fit this patient very good. That's the classic telltale sign of this condition. This patient has Paget's disease, and Paget's disease can present as skin lesions, and this one's affected the breast, and can't even see the nipple would be right there. So this is Paget's disease of the breast. Right? Definitely a plaque. We can see where the tissue stops and the lesion starts quite abruptly. Right? There's a hairy one. It's rough and lumpy bumpy, but nevertheless, the skin stops, the lesion starts. It has a very clearly defined border. So therefore, this is a plaque. And we've looked at this, right? That's chronic plaque psoriasis. So now you know what a plaque is. It's definitely bigger. Now here, maybe that's a papule. That's probably not that psoriatic lesion. So psoriatic lesions don't always have to be plaques, although with the passage of time, that one will probably be engulfed in there. That one's probably a little bigger than, what do you think? Is that bigger than a AAA battery? Probably just a touch, so that's still a plaque. And remember from last lecture, psoriasis, the lesions classically have that little white silver coating on them. That's classic of psoriatic lesions. How about this one? I think I took these slides out too to put more of the cancer in, but I have a lecture on this on my website. On my main chirogeek.com website. So this is called exanthelasma. These lesions here are very similar to the plaque that is inside people with coronary artery disease, with atherosclerotic disease. They're actually foam cells that live in here. If you ever see this on a patient, and they haven't had their blood tested for lipid levels and cholesterol levels, they have to be tested. About 50% of these patients will have dangerously high levels of cholesterol. I'm not talking about 250 or even 300. I'm talking about 500, 600. And it will definitely shorten their life if they're not on treatment for this. But this is an example. It's definitely a raised lesion. This part is bigger than a 1 centimeter. So that would be a plaque. But this one's not. Okay, so there is a papule. So this xanthelasma, now it's coming back to me, xanthelasma lesion is demonstrating both a plaque and a papule in the same lesion. Now, finally, the tree bark. So lichenification. This one is a little tougher to find the border on. It's a raised lesion. It could really be any size, but they're almost always bigger than 1 centimeter. And it's classically said to look like tree bark. The key is the borders are not well defined. No, this guy, lichenification man, I think these borders are probably a little too sharp. So this would probably be Plaque man, would be a better example, but couldn't resist throwing that one in there. Lichenifications, the skin appears thick looking, accentuated skin markings, but the key is you can't see where the thing stops. It does not have a well-defined border. It's usually seen in the eczematous conditions. We'll look at some of those in a second. Here's a perfect example of a contact dermatitis, latex glove allergy. And the patient goes, God, my skin's getting kind of weird looking, isn't it? It starts getting itchy, and he's been itching it here and excoriated here. But see, it's like someone put a big magnifying glass right here and is looking at it. But where's the borders of the lesion? I mean, it's really hard to tell where the lesion and the normal skin start and stop, and if this finger's affected as well. So this is a lichenified lesion in a patient with contact dermatitis. Patient presents with lichenified lesions. Working diagnosis is contact dermatitis, probably from latex. Here's another one. So this is LSC, lichen simplex chronicus, which is caused and perpetuated by patient scratching. Let's see. Hang on 1 second. All right, so it's perpetuated by patient scratching. Yeah, there it is, LSC. Lichenification, if you look histologically at it, you can see that there is some bubbling going on. There's some effusion down underneath the skin. So there's an inflammation process of some kind going on, and it's bubbling and pushing the skin up and causing that accentuation. It's not a blister, though. This is not a blister. That skin is still really thick. Look at blisters the next lecture. What are the causes of lichenification? The eczemas, as I said, aka eczematous dermatosis is another cause of that. What's an example of some eczematous diseases? Atopic dermatitis and allergic contact dermatitis, irritant contact dermatitis. So there's two flavors of of contact dermatitis that we'll get to. If not, I already have a YouTube video on those for sure. What else did I want to say about this? Right now, I want to get this notion out of your head. Eczema is not a disease in and of itself. Despite what you may hear, eczema is a description of a lesion, a skin lesion, from the disease, like atopic dermatitis would cause eczematous lesions. Got that? So eczema in itself is not a disease. It's a type of lesion. Apologize in advance. It's Friday, and it's garbage day, so we got the 3 garbage trucks rolling through here. I can hear them coming, so apologize in advance. Psoriasis is another type of disease that early on, we just looked at plaque. It typically causes plaques, but it can cause lichenifications, especially when the lesion is just kind of starting out. Some more causes of lichenification. We already said LSC on the other page. There's the mycosis fungoides, Dr. Doe's realm. They can cause it as well. Pemphigus vulgaris, we talked about bullous pemphigoid last week. Remember, that's an autoimmune disease against hemidesmosomes, specifically against BP230. It's the most common blistering disease. This is another common blistering disease, but this one is more deadly. And this is, remember I gave you the analogy of the pole vaulter, snapping his pole and more deadly. This pemphigus vulgaris is an autoimmune attack on desmosomes, so you get much more swelling and inflammation that bubbles up to the surface and can cause a lichenified appearance. All right, here's an example. One of the most common places for eczema or from psoriasis to actually pop up. Here's an eczematous lesion right here, right in the gluteal clefts here. And we're going to see that because we usually, when we're treating in low back, you kind of pull the pants down just so you can see right about this region. So you might see it kind of peeking at you. So psoriasis can present right there. This is called, has a word, this presentation. This is called gluteal pinking. Gluteal pinking. Okay. All right, Lentigo. Got to talk about Lentigo. Super, super common. A lot of AKAs. I got plenty of these little spots on me. Liver spots, they're called, because I guess someone thought they look like the color of liver. Old age spots is a really common one. A lot of authors, dermatology authors, call them solar lentigo. I've heard lentigo senalis because it's in the senile, you get old, I guess. This is not politically correct these days, so I doubt you'll see these on any boards because of the way our state our world is in right now. It's disparaging to old people, so let's call them old age spots. That's still disparaging to old. How about liver spots? I don't know. Where does it end? But anyway, these are all common AKAs. This is pronounced Lentigo. Lentigo. They're typically, that's a perfect one. They're like liver color, like a light brownish color. They can be any size. They can be a 1 centimeter macule, or they can be a 5 centimeter patch. They are typically more prevalent on sun-exposed areas. The surface is smooth. It is not crusty. These are not raised lesions. If you can close your eyes and you feel it, it's not a lentiginous lesion. So this, we'll talk about the keratoses later, super common. The seborrheic keratosis, the great imitator, and the actinic keratosis, that's squamous cell, that's considered pre-squamous cell carcinoma. So lentigo lesions can be darker or even black occasionally. Most of the time they're liver color though. It can be variegated, different colors. Variegated means different colors. Can they become cancerous? Well, it doesn't happen often, but they can. There is a path they can follow. So they, especially when they become variegated, they can start to get a little more densely variegated. And then you worry that they've gotten into the dermis or close to the dermis layer. And when they become variegated and you biopsy, and sure enough, you have a dysplastic, a few dysplastic cells in there, then it's called lentigo maligna, and that's a precancerous. And the way I'm teaching pathological lesions from Robbins, that would be a stage 1 dysplastic lesion. Stage 2 and 3 are flat out cancer. Stage 1 is considered a precancer. What about a metaplasia? Somebody asked me yesterday. Metaplasia. Some authors declare a metaplasia a cancer, a precancerous lesion as well. Like Barrett's esophagus is a metaplasia of the distal esophagus, as we've already learned, where it becomes intestinalized. Those cells are typically metaplastic, and the majority of authors do call that a precancer. Technically speaking, it's a precancer because it hasn't morphed into dysplasia yet. Once it morphs into type 1 dysplasia, now there's no question it is a precancerous lesion. Once it morphs into dysplasia 2 or 3, it's definitely a cancer that you need to get out of there. So lentiginous lesions are typically not variegated yet. If they are variegated, then it's probably lentigo maligna or lentigo maligna, or it's probably lentigo maligna. So if your freckle, your old age spot, all of a sudden it becomes variegated, then it raises the suspicion that you have some stage 1 dysplastic cells in it, and it is precancerous. What's precancerous? Lentigo maligna is precancerous. If that variegation gets more coarse, and we'll talk about this, we have more slides in this later, but if it gets really deeply variegated where you have a black and you have light brown, then you probably have a melanoma, and it's a deadly form of cancer. It usually happens on the face and would be called lentigo malignant melanoma at that point. So just planting seeds right now. We'll follow up with that later. So here's a perfect example. Here is a lentigo lesion that started to become variegated, and then even worse, it started to grow some bumps on it. That is not a good thing. It was biopsied and ended up being lentigo maligna, but it definitely is on its way to becoming, it could have easily been lentigo malignant melanoma because of these bumps here. So if your single color lentigo lesion suddenly changes to multiple colors, or just even 2 colors, you need to get it checked. If it developed nodules, you need to get it checked because it's headed toward cancer. All right, the lentigo lesion, and most of the time people will live with this their whole lives and no big deal. It does not extend into the dermis. If it does crack into the dermis, it's lentigo maligna. If the histologist sees cells going all the way down into the bottom of the dermis or even the subcutaneous tissue, then you got yourself flat out cancer, a melanoma, dangerous lentigo malignant melanoma. What are the risk factors for getting this? Sun exposure is a risk factor for all of these cancers. Huge risk factor. Just getting old, that's where the senalis comes from, and the old age spots, all those AKAs. Caucasians tend to get this. They're not protected against the sun like people of color are. Let me check something there. Okay. All right, let's take a look at some. We've seen these now. You go, oh gosh, I've seen these. Your grandpa has these. Maybe your dad has 1 or 2 popping up. But these are sun-exposed areas, and that's just run-of-the-mill lentigo lesions, no big deal. This one is way bigger than, it's a big lentigo, but because it's variegated, see there's different shades of color. We got even some reabsorption here going on. We got a nodule over here. That's no good. That's got to be biopsied. So this turned out to be lentigo maligna, was precancers. Lentigo malignant melanoma, maybe in 10 years this would be really black and this would be light. That means it's coarsely variegated. So that is the kind of indication that it's become flat out cancerous. Ephelides versus Lentigo, or Freckles versus Lentigo. What's the difference between these type of lesions? So freckles are really common, no big deal. Lentigo lesions are not darkened by the sun. So when you look at Grandpa in the winter, he's got those kind of dark lesions, those old age spots on the back of his hands. In the summertime, they look exactly the same. But when Junior, with some nice freckles here under the eyes, in the winter they're light brown. When he goes out in the summer, they turn black. So that's one of the best ways to tell the difference between Ephelides and Lentigo. Okay, so Ephelides freckles quickly darken with sun exposure. What are freckles caused from? They're actually melanocytes that have become hyperactive. Maybe Junior's hyperactive as well. All kids have tremendous energy, right? And this little collection of melanocytes also develop. Gosh, that garbage truck sounds loud, doesn't it? You guys got to be able to hear that, because I'm using my Yeti today, which picks up everything. But yeah, so it's not a hyperplasia. It's not a cell proliferation of melanocytes. The same number of melanocytes, they just became hyperactive, right? And if they're hyperactive, they produce too much melanin, and they overinject the carotenocytes next to them. And those carotenocytes, which are turned over, about every 24 days or so, the new carotenocytes are constantly falling off and being replaced. Talked about that already. What else? Lentigo lesion, what's the deal with them? This is not, because it's in old people. Old people are definitely not hyperactive usually. But this is from a flat out too many melanocytes. That's an example of cell proliferation is going on, right? So there's too many of them. And it's not that they're injecting too much melanin into adjacent carotenocytes. There's just too many of them, so they're become proliferative. Right, and then the last example, well, the lentigo lesions are usually seen in old age, and the Ephelides are seen in younger people. Right, nice example of ephelitis lesions, or freckles, you could say. And a nice example of Grandpa in the summer. You can see it's the summer. He's got, he's not worried about his tan, but he's got some exposure here. You can see where he wore some kind of turtleneck or something, or some collared shirt. But even the ones up here haven't turned black or anything from his sun exposure. When do you biopsy a lentigo lesion? Kind of said this already, but anytime you get an irregular border, if it becomes variegated in any way, if it develops a thickened appearance, or even worse, if it develops nodules of any kind, then it needs to be biopsied to make sure it's not precancerous. How do you treat these? So there's a big treatment class of medications called the retinoids. There's all sorts of retinoids. The main ones I'm going to talk about are tretinoid cream. Tretinoid is an AKA for retinoic acid. Another one is called tazarotene cream, and those will lighten. They won't get rid of them, but they'll lighten them up quite a bit. It's about 83% effective at significantly lightening these lesions with the passage of time. There is some laser therapy, a Q switch that works good on the hands and arms. Right? There's chemical peels that you can try, which destroys the epidermis without destroying the dermis below, hopefully. There's TCA has been used, another type of chemical peel, fairly effective. Here's a TCA peel, trichloroacetic acid peel. There's the before and there's the after in this patient. So see how it kind of lightens them. There's cryotherapy has been used, touted to be very effective. It's kind of hit or miss from what I've read on it. It works better in Caucasians. Problem with this one is it can leave hyperpigmentated or hypopigmentated spots. All right, let's go on to melasma. So that's called the mask of pregnancy. Some of the AKs for that. Cloasma, faciae. I'm going to call it melasma. That's probably the most common. This called the mask of pregnancy because pregnant women are notorious for breaking out with these blotches on their face. And that's typically what it is. And they can be pretty big sometimes. So let's talk about it. It's a very common acquired light and dark brown hyperpigmentation disorder of the face. So they get these macules and even patches on their face of different colors. And they're oftentimes patches. They're quite big. They rarely show up on the neck. They like the face. The sunlight is a risk factor for these things, by the way. They can darken sometimes. They love the molar eminences here, or the cheeks, the upper lip and chin. Let's take a look at one here. Looks like this one's been treated. It's fading away. But that's a big patch, even with some kind of regression of some of the lesion in here. But that's a big patch. It's pretty light, but nevertheless, this is melasma. How do you know that's not lentigo? Lentigo are usually oval-shaped lesions. These are very wide and dispersed and scattered lesions. That's the way you can tell the difference. Sometimes you can't, though. I mean, that's kind of a flat-looking lesion, so it can get confusing sometimes. That's a differential diagnosis, but that is not a lentigo or lentiginous lesion. That's definitely melasma. They tend to have a blotchy appearance. They can consist of macules, but oftentimes patches. So they're not dangerous. They don't become cancerous or anything like that. But psychosocial issues are huge. My wife has a few of these. They're quite faint, I think. She thinks they're, of course, terrible looking. I'm like, I can't even barely see them. But women can become very aware of them. What is the cause of these things? Well, very similar to lentigo. There's an increased number of melanocytes that are found in the stratum basale where they're supposed to be. The melanocytes can actually, they're where they're supposed to be. I don't know why I put that. That's where melanocytes are. There's just an increase, just like lentigo, there's an increased number of melanocytes. And therefore, if there's too many melanocytes, they're producing too much melanin. These are not moles or nevus cells. We'll talk about melanoblasts and that when the time comes. I think that's our last lecture. They're scattered, widespread, as we said. Lentigo can be widespread, but it's solitary lesions. Like Ephelides, the melanocytes do become a little bit hyperactive in this condition. So it's kind of a combination of both then. So the melanocytes are not only too numerous, but the ones that are there can be hyperactive as well. Okay, let's look at, there's a classic lesion of melasma. You see how it gets up in the lip here as well? Another one. Looks like it's been treated because it's fading away, but it, kind of gets in the upper lip there, gives that mustache look, which females probably don't like that. Pregnancy, the mask of pregnancy, because it shows up during pregnancy. Estrogen has something to do with this, we believe. After the pregnancy disappears, sometimes they go away, but they typically come back later in life. If you've got them when you're young and pregnant, they'll probably show up later. Hispanics, my wife is Hispanic, and my daughters have these as well. So there's definitely a genetic connection to these things, but Hispanics seem to be particularly susceptible. African Americans and Asians can also get these, are more susceptible than Caucasians. And the pigmentation can develop very slowly. There's no sign of inflammation. This is not an inflammatory disease. I do like that test question because just about everything is inflammatory, but this is an example of a non-inflammatory condition. Risk factors for melasma. The strongest risk factor is genetics, family history. UV radiation, so sunbathing. Being female, this is a female problem. 90% of those affected are females. And it could be more males are affected, but males, especially when you get older, you don't really care that much about these lesions. Maybe that's it. I don't know, but it seems to be a female problem. Pregnancy definitely brings them on. Any estrogen therapy can bring them on, like estrogen progesterone therapy for menopause. Thyroid dysfunction, cosmetic irritation. Maybe you've got a contact dermatitis from some new makeup that you're using that can set them off. And strangely, we might see these more than other providers, is some very common medications for sciatica. We have Lyrica and Neurontin also increase the chances of breaking out in these things. Another example, looks like she had something removed right there, right? See that scar right there? Hispanic. Differential diagnosis has got to be Lentigo. Hyperthyroidism can bring on skin lesions and hyperpigmentation of the skin as well sometimes. HIV infection can bring on lesions. We actually looked at some already. And pigmented cosmetic dermatitis is you're constantly being allergic to your cosmetics causes it. Really tough to treat this one. Unlike the port wine stain, this one's tough to get rid of. Combined therapy or a triple therapy seems to be the treatment of choice, and that's a combination of hydroquinone, tetranone or retinoic acid, and this fluocinolone acetonide are the treatments for this. There's some other ones as well, some other research. There's some hypopigmenting agents. There's topical retinoids with steroids, chemical peels, PUVA therapy. That has some radiation involved with it. I'm not a big fan of that one. And some laser therapy. What's the prevention and treatment? I mean, if you can't treatment, or if treatment's not working, you just have to put makeup on. But be careful to make sure the makeup isn't causing these things. And then minimize your exposure to the sun. Remember, you go out in the sun now in your 20s, this may not get you until your 40s or so. But if you don't want these to develop, especially if mom and grandma have these things, you're at really high risk for these. So you should really take it easy. If you're going to go in the sun, make sure you block both UVA and UVB radiation. It's another picture of one. Great website, by the way, this Derm.Net New Zealand. They put up a lot of pictures and they do a nice job. Just another one. All right, so that's enough for your brains today. I will see you all next week.